I've just prepared a slide for you that's you're gonna hang tight all of the questions that are frequently asked in the USMLE Step 2 CK about aortic dissection. First of all, it's a high yield topic and it's a frequently tested topic, so most of the things are covered in this presentation, and we'll not discuss much about the pathophysiology because that is more of a step 1 portion that is tested. We'll put an emphasis on like the management portion for the step 2 CK. So giving a brief little introduction, as you all know that aortic dissection has two types. It's the Stanford type A, that's called ascending, and it's the Stanford type B, that's descending. So what could be the most common presentations for the aortic dissection? So whenever a patient presents to you with aortic dissection, he will be presenting most of the times in the emergency department with a ripping chest pain. He'll be complaining that he'll be having a tearing chest pain, and that is mostly but not always radiating to the back. And for the chest, as the chest pain is considered, like the anterior chest would be involved in the ascending types of aortic dissection, and the back of and the back will be involved in the descending types of aortic dissection. And some other key features that would help you in diagnosing the aortic dissection at first hand would be the significant difference in the BP, like BP difference would be like 20 millimeters of mercury in the systolic and like 10 millimeters of mercury in the diastolic. Blood pressure, there would be wide pulse pressure, and there would be hypotension or hypertension. So hypotension would be like due to the blood loss or shock, and hypertension would be, as you all know, it can be due to the pain. So keep that in mind, or some underlying hypertensive disorder. So these things you have to keep in mind in discussing a case of whenever a case of aortic dissection comes into the exam. So now we are moving to the main portion, that is frequently testing, like the management of aortic dissection. So we have to do a lot of diagnostics for the aortic dissection. So first of all, I would like to list them all. It's like chest x-ray, transthoracic, echocardiography, or point of care ultrasound. When you have to do all these imaging, and which imaging is considered in which condition, that is my focus on the next part of this video. So chest x-ray, transthoracic ultrasound, and point of care ultrasound are some low sensitivity tests that are only to be done when the patient is too unstable. So whenever a patient with aortic dissection comes and you see that the BP is considerably low, like the patient is going in shock or hypotensive, is highly hypotensive, so and there is no time to do a CT angio or a transesophageal echocardiography, then you have to do a transthoracic echocardiography. That is like the most likely answer, that will be the most likely answer in the given scenario. Or you can do a chest x-ray that will show a widened mediastinum, or you can do a point of care ultrasound. Secondly, if the definitive imaging is not available at a facility, you can go for these testing. Or if the patient is low risk, you do not consider it to be a case of aortic dissection, just to rule out, as you know that we can do these diagnostics as like chest x-ray, transthoracic echocardiography, or point of care ultrasound. Now coming on to the definitive management, it would be like this CT angiography. CT angiography is the gold standard for diagnosing aortic dissection. So whenever the patient comes with a complaint of aortic dissection and he's considerably stable, first step, the next step you're gonna do, and you're considering him to be high risk for aortic dissection, the option you're gonna choose is 100% CT angiography if the patient is stable, because it's the gold standard. And secondly, you can opt for the transesophageal echocardiography or MRA. Transesophageal echocardiography can also be done in the unstable patient, but as it's less time consuming than CT angio. But if the patient is too unstable, we go for transthoracic echocardiography. And if the patient has like a kidney disease or difficulty creating creatinine, then we do not opt for transesophageal echocardiography. and if both of these options are not available, then we can go for MRA as well. So this was the diagnostic like imaging for aortic dissection. Next would come the treatment. The treatment is simple and it's very often asked in the USMLE Step 2 CK. It's a high yield topic for Step 2 CK. So we have different management plans for ascending and descending aortic dissections. So for ascending aortic dissection, we are gonna immediately go for thoracotomy. So we are not gonna waste any time. The patient is bleeding, we're gonna go for thoracotomy, surgically open and fix the aorta. So that would be the treatment for ascending aortic dissection in most of the cases. For descending or type B aortic dissection, we're gonna go for watchful waiting, and that includes the conservative management, like we'll give the beta blockers, like IV beta blockers, and the followed by the IV vasodilators like sodium nitroprusside. For beta blockers we mostly use esmolol or propranolol, and for vasodilators we use mostly the sodium nitroprusside. For pain management we mostly go for morphine. So whenever you find out that cases of an ascending aortic dissection, the most right and the most the right answer would be the thoracotomy, and whenever it's a case of descending aortic dissection, in most of the cases the answer would be like IV esmolol, IV propranolol. Don't get confused with the oral option, because in some cases they can confuse you with oral options as well. So don't choose oral option, always go for IV. So IV beta blockers and followed by the IV vasodilators, and for pain control we use morphine. For hypertensive patients we use like these medications as discussed. For hypotensive, the patient is what if the patient is hypotensive? Then we don't use this, we just go for the vasopressors. We build up the blood pressure back to the normal. So that's just the case for aortic dissection, and I don't think any question can come outside of our point of discussion in this whole topic. So focus on it, memorize it well, and hope it will answer all of the questions.